You're listening to This Week in Cardiology from theheart.org on Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or Alexa, what's my flash briefing? I hope you'll join us.
Hi everyone, this is John Mandrola from theheart.org Medscape Cardiology, and this is This Week in Cardiology for October 8th, 2021. This week, the New England Journal of Medicine publishes 2 papers on messenger RNA vaccine-related myocarditis, atrial fibrillation and stroke, intensifying blood pressure medications, and coronary CCTA and high-sensitivity troponins. First, an announcement. Next week, I'll be at the European Association of Cardiothoracic Surgery meeting in Barcelona, and This Week in Cardiology will take a break and return in 2 weeks. On Wednesday of this week, New England Journal of Medicine published 2 observational studies, both from Israel, which characterized the prevalence and clinical features of post-messenger RNA vaccine myocarditis. The first paper, first author, Mevarich, retrospectively reviewed data from late December 2020 to May 31st, 2021, regarding all cases of myocarditis in the Israeli health system. Now recall that Israel was a world leader in early COVID vaccination. The denominator of this study was huge at 5.1 million people who received 2 doses of the Pfizer vaccine. The authors looked at the occurrence of myocarditis in 3 ways. First, they calculated the risk difference for the incidence of myocarditis after the first and second vaccine dose. The second way, by calculating the observed to expected incidence of myocarditis for the 3 to 4 week period after the first and second doses. And the third way they looked at this was by calculating the rate ratio 30 days after the second dose compared with unvaccinated persons. A total of 304 myocarditis cases were reported in the Ministry of Health. 21 of these cases were ruled to have an alternate cause, and of the remaining 283 cases, 142 occurred in vaccinated persons within 3 weeks of the first dose or 4 weeks after the second dose. The cases of myocarditis within the time window of vaccine were generally mild, with resolution of clinical symptoms, ECG changes, and troponins in a matter of days. However, 1 person with fulminant myocarditis died. Magnetic resonance imaging that was performed in 48 of these persons showed findings that were consistent with myocarditis. Now, 19 cases occurred after the first shot versus 117 after the second dose. 95 of 117 persons, or 81%, who presented with myocarditis after the second dose were hospitalized. Now, Figure 1 from the New England paper shows a clear predominance of myocarditis in 16 to 39-year-old males. Table 3 from the paper shows the clearly high risk of myocarditis after the second dose. And Table 4 of the paper addresses the observed versus expected incidence. And they did this by age group, but among 16 to 19-year-old males, the observed versus expected incidence ratio was 13.6 times after the second dose. And among males in the 20 to 24 age group, the observed versus expected was 8.5x after the second vaccine dose. The rate ratios for females were also increased in the younger age groups, but the absolute numbers there were smaller than in the males. Now, the final data point was the rate ratio between vaccinated and unvaccinated. Again, the most prominent findings here were in second doses in young males. For males 16 to 19, the rate ratio after the second vaccine, vax versus unvax, was 9. Now, the authors write in the first paragraph of the discussion that myocarditis among persons between the ages of 16 and 19 after the second dose occurred in approximately 1 in 6,600 male recipients. Okay, second study in New England. The first author here is Whitberg, and Whitberg and co-authors searched the database of the largest healthcare organization in Israel looking for the diagnosis of myocarditis in persons who had received at least 1 dose of the Pfizer vaccine. The denominator in this study was 2.5 million vaccinated members of this healthcare organization, ages 16 and up. Total number of myocarditis cases was 54. The highest incidence of myocarditis was reported in male patients between the ages of 16 and 29 years. Their estimate was about 1 in 9,300. Now, 3/4 of the cases in this study were described as mild, 22% as intermediate, and one case was associated with cardiogenic shock. The lower rate of 1 in 9,300 in young males compared with the Ministry of Health data may be explained by different time windows. In the Meverach study, the first study that I spoke about, they looked at 30 days after the second dose, whereas in Whitberg, the second study, they looked at 42 days post for dose 1. So it's conceivable that in the second study, some of the post-second doses were missed. My comments on this are that these are important publications, not so much because of the specifics. We sort of knew that there was a low incidence of messenger RNA vaccine myocarditis. We knew its predilection for young males and its increased prevalence after this second dose. I think what's most important about these studies is that publication in New England Journal of Medicine and coverage in the New York Times now allows a discussion about an adverse effect of a therapy. And my friends, that a therapy has an adverse effect does not diminish it. I mean, life-saving therapies, insulin, antibiotics, pacemakers, all can cause harm. Now, maybe I'm naive, but I see the messenger RNA vaccines as I do any other therapy in medicine, with harms and benefits. And the benefit of these drugs in older adults is massive and amazing and clear and far outweighs any harms. But if you combine the logarithmic age grading of COVID-19 severity in younger people, plus the signal of vaccine myocarditis after 2 shots in young males, there ought to be room for a discussion about different harm-benefit ratio calculations in younger people. And to me, in this discussion, one must recognize that some of these vaccine myocarditis cases were severe and even fatal. That matters. Yes, it is accurate to say that most vaccine myocarditis cases were mild, but medicine is frequently practiced in the tails of probability distributions. For instance, we turn ourselves inside out to never miss a single STEMI or PE. We lose sleep over a rare complication that we cause during a procedure. We hardly feel satisfied saying most of our patients didn't have a complication, or we picked up most STEMIs. Tail events matter to us and our patients. And yes, of course, tail events also occur with SARS-CoV-2 infection as well. Young people can get very sick from the virus even though it's rare. That's part of the calculus that individuals should be allowed to make along with their clinician. Finally, and then I will move on, the myocarditis signal does not argue for not vaccinating younger people. It argues for a way to do it most safely. Numerous countries in Europe are modifying messenger RNA vaccination regimens based on these myocarditis signals. Why should the U.S. be any different? All right, next topic is stroke and atrial fibrillation. JAMA Cardiology has published an interesting paper looking at the temporal association of an AFib episode and stroke. And you might ask, why is that interesting? We know being in atrial fibrillation causes stroke because of stasis and LA thrombus formation and embolism. But actually, the causal relationship of a single AFib episode to stroke is not so clear. AFib episodes might simply be a risk marker for stroke. And the trends, observational data, show that the time correlation of an AFib episode and stroke is quite weak. In that paper, most strokes in patients with AFib did not have an AFib episode anywhere near the time of their stroke. And here's another important issue. Let's take a relatively low stroke risk person, has an episode of AFib that lasts, say, 10 hours, one episode. Their CHA2DS2-VASc score is 2, so boom, they're put on anticoagulation, sometimes for years, decades, or life. That always bothers me. And this problem is getting worse with the advent of wearables. What do we do with a 58-year-old woman who takes 5 milligrams of lisinopril for mild hypertension, who has one 6-hour episode of AFib on her Apple Watch? One episode. Does she take anticoagulation? For how long? For life? I mean, for one episode? I really worry about committing people to lifelong anticoagulation for short duration atrial fibrillation. This paper, led by Dr. Dan Singer, used a case crossover design in which each patient acted as his or her own case and control. Here's how it went. They took a large national database, the Optum database, and it was linked to a single vendor PACER ICD database. And they found patients with a cardiac device that were capable of AFib monitoring. Most all devices nowadays can do AFib monitoring. They took these patients who had an ischemic stroke and who also had 120 days of monitoring before the stroke. Now, the case period was the 30 days right before the stroke. For instance, day minus 30 to day 0, the day of the stroke. The control period was day minus 120 to day minus 90, so a 30-day period earlier. And the exposure was a 5.5-hour episode of AFib on any given day in those 30 days before the stroke or the 30 days in the control period from day 120 to day 90. Now, the main outcome was the relative risk or odds ratio of AFib that occurs immediately before the stroke versus that occurs 120 days before the stroke. And here's what they found in the database of nearly 500,000 patients. About 900 patients with a cardiac device had a stroke and had 120 days of monitoring pre-stroke. These were older patients at age 76, mostly male. And to get a ratio of this risk, you need discordance of AFib in the case and control period. If there is AFib in neither or in both, you can't tell the difference in stroke risk. So in this study, more than 3/4 of the 900 patients, 76% of the patients who had a stroke, had no AFib of more than 5.5 hours in either the case or control periods. And in 16%, they had AFib of more than 5.5 hours in both periods. Most of these were just continuous AFib. So you really can't make a distinction. So they ended up with a total of 66 patients who had informative discordant arrhythmic states, 66 of 900. And they found that more patients had AFib in the case period, 52, versus 14 in the control period. The odds ratio was 3.7. That's the first main finding of this paper. The second finding was that stroke risk was increased most in days 1 to 5 following an AFib episode. The odds ratio there was 5. And the third finding was that AFib episodes were not associated with increased stroke risk in patients taking anticoagulants. And of course, this is consistent with the stroke suppressing effect of anticoagulants on AFib-related stroke. So my comments, first thing, my friend, Stanford electrophysiologist Mintu Turakia has an excellent editorial in the paper and it's worth a read. I really like his lead-in in the editorial. He nicely lays out the extremely weak stroke prediction models we currently use. The CHADS-VAS score, for instance, was derived from 1,000 untreated patients with only 1 year of follow-up and 25 total thromboembolic events. Further, the CHADS-VAS score that we love so much for AFib similarly predicts stroke in patients without AFib. So pause there and rewind. 25 events for this CHADS-VAS score. That's it. My friends, we forget the massive uncertainty of using this simple integer score to commit people to anticoagulation for years or decades, or conversely, to withhold anticoagulation in seemingly low-risk, high-burden patients. So any effort to discriminate patients who may benefit more or less from anticoagulation is welcome. And the digital revolution will increasingly allow better characterization of AFib duration and frequency, and it seems to me that this ought to be able to be used to tailor risk. But this paper mustn't be misinterpreted, and I want to echo the author's conclusion statement, quote, "It would be premature to base anticoagulation decisions in patients with subclinical AFib on our results," end quote. I see two main limitations of this analysis. And one is that crossover studies in 66 of 891 patients with stroke may hint at AFib being directly causal for stroke in these patients. But remember, the vast majority of patients with stroke had no AFib, or they had AFib in both periods. What's more, this study speaks in relative risk increases of stroke. The absolute risk of stroke in these patients is crucial. If the absolute stroke rate is high enough, it doesn't matter if there is an increased risk right after a 6-hour episode of AFib. For instance, if someone with AFib has a 1.5% or greater annual risk of stroke, there is likely a net benefit of continuous anticoagulation. Now, the authors argue that this data supports a trial comparing time-delimited anticoagulation covering only multi-hour AFib episodes versus continuous anticoagulation in patients with infrequent paroxysmal AFib. But I'm trying to figure out how to do such a trial. I mean, to ethically randomize patients with AFib to non-continuous anticoagulation, you'd have to enroll low stroke risk patients. So the event rates will be very low. And if the event rates are low, this means a bunch of patients would have to be enrolled to show a difference in heart outcomes. Also, you'd have to have near perfect AF detection from the wearable, and I'm not sure we are there yet, though the technology is impressive. Next topic is intensifying blood pressure control. Now, this question comes up often. A patient on 1 or 2 blood pressure meds has a high reading and you want to improve blood pressure control. Do you add a new medicine or increase the dose of a current medicine? A group from the University of Michigan, first author, Dr. Carol Aubert, studied the two approaches in a retrospective cohort study in veterans. Patients had to have a systolic blood pressure greater than 130, and they had to be on at least 1 blood pressure medicine at less than maximal dose. The authors then studied the 2 intensification approaches. One was adding a new medicine, and it's defined as a total dose increase with a new med, and the other, maximizing dose, defined as a total dose increase without a new medicine. They then used inverse probability weighting to assess the efficacy of the intensification approaches on A, sustainability of the intensified treatment, and B, the follow-up blood pressure at 3 and 12 months. The 3 main results of this paper were that increasing doses was the more common choice, 75% versus 25%. Adding a new medicine compared with increasing the dose of an older medicine was associated with less sustainability of the intensified treatment, but adding a new medicine also resulted in a slightly larger reduction in systolic blood pressure. I like this study, which was published in the Annals of Internal Medicine. It's a complex methodology, but it addresses an important trade-off that practicing doctors face often. Yes, a new medicine may be more efficient in reducing blood pressure, but the pragmatic effects of an extra pill cannot be ignored. These pragmatic effects are less of a factor in trials, because in trials you're enrolling motivated patients who are well enough to comply with trial protocols, and they have trial support staff who look after the patients with greater rigor than is possible in the real world. And in the real world, the new pill means getting a new prescription at the pharmacy, higher cost, more organizing of the pill containers. That extra work of being a patient should not be discounted. So yes, increasing a pill may produce a slightly less potent effect on blood pressure, but the gains in sustainability may win out over effect size. The authors write that a trial would be needed to sort this out, and I think actually it could be done, perhaps as a pragmatic, simple trial that's just embedded into the EHR. It would be an interesting study. Final topic today is troponin-guided CTA after myocardial infarctions has been ruled out. To date, most efforts in the emergency department of patients is to rule out or rule in MI. Patients who rule in are easy. They get admitted and treated. The advent of high-sensitivity troponins in CTA may be able to further risk stratify and improve outcomes in those patients who are ruled out. The Nicholas Mills Group in Edinburgh, Scotland, have published a prospective cohort study of patients in the emergency department who came because of suspected ACS. Jack published a study. Patients were recruited in a 2-to-1 fashion, and they were stratified by peak high-sensitivity troponin concentration above and below the risk stratification threshold of 5 nanograms per liter. All patients underwent CTA angiography after hospital discharge as outpatients. The total sample included 250 patients, 61 years old, 31% female. Okay, those with intermediate high-sensitivity troponin levels, above 5 but less than the MI cutoff, 99th percentile, were more than 3.3 times likely to have coronary disease on a CTA than those with troponin levels less than 5. It was 72% versus 43%. Most interesting, though, was that there was no association between angina symptoms and CAD diagnosed by outpatient CTA. Finally, most patients with CAD diagnosed did not have a previous diagnosis. Over half of them were not on statins or aspirin. So the authors concluded that even in patients who were ruled out for MI by high-sensitivity troponin, coronary artery disease was 3 times more likely in those with intermediate high-sensitivity troponin concentrations compared with low high-sensitivity troponin. And thus, CCTA might help identify those with occult CAD by targeting preventive therapies, and this may improve clinical outcomes. Okay, my comments. The Edinburgh group is ahead of most places here in the U.S. Most of our places haven't transitioned to high-sensitivity troponin assays, which are used to make a decision binary. That is, rule in and be admitted, almost always get cath, or rule out, go home, and get a functional stress test as an outpatient. I am drawn to this study because we know that high-sensitivity troponin levels are a continuous risk marker. Very low levels portend low risk and allow rapid discharge, but those with intermediate levels of high-sensitivity troponin have a higher future risk. And the observation that they are more likely to have CAD on CTA could explain that increased risk. Of course, we know from the Ischemia and Courage trials that early revascularization does not improve outcomes over medical therapy, so the advantage of discovering this incidental coronary artery disease is to get more of these patients on preventive therapy, say lifestyle changes, statins, and aspirin. My problem, though, is, of course, that once CAD is established and known, I wonder if patients, especially here in the United States, will then be more apt to present with more symptoms, like in the FAME2 effect, where having disease without a stent creates subtraction anxiety. Another interesting finding from this paper was that angina did not predict disease at CTA. Right now, guidelines recommend the use of clinical judgment to select patients for invasive or non-invasive imaging after MI is ruled out. Well, if angina was not predictive of CAD, that creates a problem because currently, typical angina symptoms certainly carries a lot of weight in the mind of most clinicians. A question I'd have for the authors is, okay, you've diagnosed CAD in many patients who've not had the diagnosis. More patients are on preventive therapies. But of these patients who are, age 61, how many would have qualified for statins based simply on a 10-year risk with a simple pooled cohort equation? And my final comment, we must remember that even atherosclerosis seen on a CTA is a surrogate marker. The events we care about are MI, stroke, and death, and we need to know whether the extra imaging and risk stratification leads to fewer events. Fortunately, the authors are enrolling the patients now in an outcomes trial called Target CTCA, and that's great. So that's it for this week in cardiology. As always, I'm grateful that you listened. If you like this podcast, please take the time to give us a rating, write us a brief review, let us know what you think. It helps others find us. And I will see you in 2 weeks. This is John Mandrola from the Heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org on Medscape.